Welcome to PharmaDocs with your host, myself, Dr. J. Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice.
Good evening.
Whoop, there we go. Now you can hear me.
All right, Jay, good evening. How are we doing out there?
We're doing great. What's going on with you?
Oh, man, nothing,
Looks like you're all dressed up. You make me look like a slob.
Well, we're right in the middle of our Mardi Gras carnival season, and so I had an event earlier this evening, and then I just got home, and I thought I'd just leave everything on for our PharmaDocs show.
Looks good. You're setting a new standard.
Yes, we may just have to start wearing coat and tie every other week.
Yeah,
all right.
Exactly. Yeah, good. So we got, for so long, we had so many new drugs that were being approved every week. We had a lot of drugs to talk about. There's only one new drug we're going to cover tonight that everybody should know about. And then we're going to talk about blood thinners, Coumadin.
Right. And we're going to get back into our life-threatening drug-to-drug reactions that, the top 10, and there are some in there for dentists as well too, Jay. And, you just said about the new drug approvals. I tell you what's happening right now. We're seeing a lot of EUA, emergency use authorization approvals right now. Like we talked about this earlier about some of the new COVID by mouth drugs, which are very similar to like a Tamiflu. That's Pfizer's drug Paxlovid, and Merck's new drug Amlodipine. And so those will be our by mouth. Those are being approved for EUA as well too. And then we're going to start seeing more and more new drugs coming in. But I'm just telling you, guaranteed for everybody listening out there, you got 50 new drugs coming out every year.
At least,
and my partner and cohort on this show, Dr. J. Reznick himself, said it best. If you've been out 10 years, that's 50 new drugs. That's 500 new drugs in your practice lifetime that you got to know about.
Yeah.
Period. All right.
Or at least know kind of what they are so you can look it up.
Absolutely. And again, we've told you over and over on our show, let your assistant go in, get everything, and then you come back and review the chart. If there's a medicine you don't know, use your drug tracker.
Yeah.
Look it up.
Exactly.
That's right.
So you go in there advised and aware and informed. So when you see your patients, you talk to the patients, you know what questions to ask.
All right, tell me about Pyrukynd.
So Pyrukynd that's the new drug that was approved this week, a week ago, February 17th. And this is a first-in-class, first approved disease-specific modifying drug for pyruvate kinase deficiency.
All right, stop right there, Jay. There we go again. First-in-class approved drug. We had another one 2 weeks ago.
Yeah.
All right. So, I mean, look at the advances we are making in medications as well as compromised states.
Right. This is a treatment for a disease that until now has basically been treated symptomatically and just supportively. And now there's actually a drug that gets to the heart of the problem. So pyruvate kinase, as you remember from dental school and from biochemistry, is that enzyme that's involved in the last step of glycolysis. And that's what adds that phosphate group onto ADP to produce ATP. So it's responsible for energy within cells. And the drug the gene that is defective in pyruvate kinase deficiency is the Pklr gene, which stands for pyruvate kinase liver and red blood cell enzyme.
Right.
And so, or gene. So it's basically in the liver and red blood cells that we see this defect. And when we see it in red blood cells, of course, what do we expect the outcome is going to be? It's going to be an anemia.
Yes, because our red blood cells are going to break down too easily because we don't have this enzyme. Okay,
right. They don't have their low energy, deficit in energy, and so the red blood cells can't do what they need to do, and they're broken down. So it's a hemolytic anemia.
Correct.
And with hemolytic anemia, we see things like expansion of the liver, enlargement of the spleen.
Spleen.
We see anemia. We see all kinds of effects fatigue, GI problems, all kinds of systemic disorders from this hemolytic anemia. And it can be a mild disease and sometimes not even be detected until adulthood, or sometimes it can affect newborns.
And like you said earlier, this treatment was always just supportive.
Yeah, they would do splenectomy so that the red blood cells weren't broken down and removed as to the great extent, or they would give red blood cell transfusions. And of course, both of those have significant number of morbidities associated with them, complications that can affect the patient's life. So to be able to treat this disorder, specifically hitting it basically at that enzyme, to increase the ATP in the red blood cells and decrease the amount of hemolysis. That's a big deal.
Yes, it is.
It is. It really is. And so this is a new drug that we're going to start seeing in our dental patients. We don't normally think of patients coming in and saying, oh, well, they've got hemolytic anemia, or seeing that on their medical history, but we're going to start seeing these medications, especially pyrukynd. We're going to see that showing up on our patients' medical histories, and we're going to know that this is a patient that is being treated for pyruvate kinase deficiency, a hemolytic anemia. And so we need to be aware, because there are drug interactions that we have to be aware of. In addition, just to the hemolytic anemia, any drug that affects the cytochrome P450 system will affect metabolism of this drug. So, for example, medications like erythromycin, ketoconazole, clarithromycin, all are inhibitors of this enzyme, and so, or of this medication rather, and so will increase decrease the effectiveness of it, and cause more hemolysis. So we want to make sure that we are aware of the patient being on these medications, because we don't want to inhibit. We don't want to give them anything that's going to inhibit metabolism of this drug, because it'll increase the level.
And Jay, too, again, hemolytic anemia. All right, we got to be aware of that, because somebody may write it down HA.
Yeah.
Because you and I have talked about, we're going to go over these acronyms with our audience out there.
Yeah.
Every time we get the chance, because they're going to write it on the chart, and you've got to know what that means.
Yeah, it could mean headache.
Yeah, that's right.
And so,
and it looks better coming out from your mouth saying, okay, HA, do you mean headache, or do you mean hemolytic anemia?
Right.
Your patient is like, wow, my doctor is on top of his or her game.
Yeah.
Period.
And especially if you see them on pyrukynd, then of course you're going to know, but you want to ask the patient just to clarify and make sure that they understand, that you understand the medication that they're on.
Right.
Yeah.
Okay.
All right. Well, that's good.
It's exciting to just see these first in-class drugs coming out.
Mm-hmm.
And
it really is.
We're going to see so many more throughout the years.
Yeah.
So
yeah. And this is one of the first one we've covered in a while that was not a monoclonal antibody.
Monoclonal antibody. That's right.
Yeah.
That's, or a JK as well too.
Yeah. So the one thing we don't have to worry about is immune system modulation, at least with this drug.
Correct.
All right. So let's move on and talk about our subject interest of this week, and that is the interaction between warfarin and other blood thinners, other anticoagulants, and some of the drugs we may be prescribing to our patients.
Right. So Jay, we're telling our audience about the top 10 life-threatening drug-to-drug interactions. In the event you've got a patient on warfarin and then you decide to write a certain drug, you may have led to a life-threatening situation for that patient. Mm-hmm. You are responsible for it because you prescribe that medication. Okay. And so
and you're required to know
the
interactions of medications that you prescribe with medications the patient may be on.
So last week we talked about warfarin and NSAIDs. Mm-hmm. All right. It's a no-no. All right. Just don't do it. Okay.
Right.
And if you have to do it, the COX-2 inhibitors would be much better of a choice, or Tylenol, but still check with your the patient's physician before you do this.
Mm-hmm.
All right. Again, we're going to be on a short-term basis in the first place, and you need to explain that to them as well. I'm only looking at 3 to 5 days, maybe.
Right. Exactly. And so warfarin, is a very common, or Coumadin is a very common blood thinner that patients may be on. It's an anticoagulant, and it works by basically affecting the vitamin K dependent pathways.
Correct.
So it can result in decreased production of the vitamin K dependent factors, and it can also you can also it'll affect, basically, by decreasing vitamin K, it decreases the clotting factor, so increases bleeding, decreases the risk of clots forming.
Correct. So this week's life-threatening drug-to-drug is Coumadin or warfarin with a sulfur drug.
Sulfur drugs, exactly.
So, Jay, some sulfur drugs that come to mind would be a Bactrim or a Septra.
Okay. Yeah.
All right. And why do we say that? Because dentists can prescribe this and will prescribe. Because what if we have that person with multiple allergies to almost every antibiotic you can think of? Our beta lactamases are they're allergic. They're allergic to the clindamycins. They're allergic to the quinolones. They just have a list of everything. So now you're getting limited, even the azithromycin class as well too. Mm-hmm. So, okay, what about a sulfur drug?
Yeah. Right? So sulfur drugs, also the way that they may affect production of vitamin K directly, but also by altering the intestinal flora, they affect the production of vitamin K by the intestinal flora by altering that intestinal flora, and so it may be a direct and an indirect effect on vitamin K, which affects the effectiveness of warfarin.
Yeah, because they reduce the metabolism as well as the clearance of warfarin. Now you're getting an increased effect of the Coumadin. And of course, you're going to see a higher INR, and we're going to talk about that in just a second as well too. But, you've got to make sure that you're paid, and you should know this. All right. I mean, you'll see, hey, I'm on a blood thinner, I'm on warfarin or Coumadin, whatever you want to call it. And there is that potential,
right, with
a sulfur drug to get yourself in trouble.
Yeah, there sure is. Now, what if you don't have a choice? What if the only thing you can give your patient is a sulfur drug? What do you do?
Well, there I would consult. I would do a direct phone-to-phone conversation with the person that prescribed the Coumadin on that patient.
Yeah.
So we can discuss that.
Exactly. Discuss how we're going to monitor this patient's coagulation. Let them know that we need something short term. We're not going to have the patient on the antibiotics for a long time. We're treating an acute problem, and so we need to get the patient through this acute time period. And we need some collaboration between the two of us to figure out what's going to be best for this patient, both from our therapeutic standpoint and from the standpoint of making sure they don't form blood clots.
So when you call the physician, because evidently this patient is going to need some antibiotics, you're going to talk to them. And so they're going to get a pre-surgical INR. All right. So you'll know the levels you are, and you're going to tell that physician, look, he or she is allergic to everything. The only known antibiotic I can give is a sulfur drug. All right. And I know it does interact and causes an increase in INR. Mm-hmm. Well, then your fellow medical colleague will follow this patient with you while that patient is on the sulfur drug that you prescribed as the antibiotic. And it may mean daily or every other day INR test to make sure that they can try to keep it in the proper range.
Right. We want to stay in that 2 to 3 INR.
Correct.
Now, I get asked all the time, what's the difference between a ProTime and an INR? What are we measuring with the ProTime? And the ProTime, of course, is measuring the extrinsic clotting pathway. And that's factors 8, 9, 11, and 12. And so, I'm sorry, that's the intrinsic. The external pathways is 7. And so that's what we're monitoring with the ProTime. But the thing is that the labs can vary from location to location, and the testing methods can vary from location to location. And so what the INR is a way to kind of normalize. It's called the International Normalized Ratio, a way to give a value that is the same whether it's the test is done in one lab by one technique versus another lab by another technique.
Right.
And so the INR is what we go by clinically, not just the ProTime, which is testing that external or extrinsic pathway,
and Jay,
extrinsic and common pathway.
Right. And one thing I'd like to say also, if the only choice is a sulfur drug, and that's imperative, that you're probably looking at your physician reducing the warfarin dose by about 50% during that antibiotic administration. Because again, at the most, we may keep them on for a week, but what if you have a situation where you might have to keep them a little bit longer than that? And so that like I said, they'll monitor the INR for you on an every other day basis. Okay. But again, do this in conjunction with the patient's physician. Document. Yeah. Write it down.
Absolutely.
Right?
Absolutely.
And go on this as a team concept. So, Jay, moving on from that, we'll go ahead and talk a little bit about INR. You touched base right there with the PT and the INR as well too. Yeah. So, we think about the main classes: anticoagulants, antiplatelets, and then the thrombolytics. Okay, so the thrombolytics, those are our clot busting drugs. Okay, that's when we're in trouble, and then we take them into the hospital, and we get the TPA.
Right,
okay,
right,
but
exactly.
right now we're going to talk about the anticoagulants, also known as the blood thinners.
Okay? And there are a number of them the patients may be on, not on other than warfarin.
Right, and then the antiplatelets, they work by way of inhibiting the enzymes that allow the platelets to clump together. Okay. And again, there's a large class of them as well too. But the INR, Jay, as you just said right there, is for Coumadin.
Correct.
All right.
Yeah,
that's the
only
blood
one that it's
monitoring test for Coumadin. That's correct. And you said it's going to be typical, between 2 and 3 right there.
Yeah.
All right.
Yeah. They usually shoot for about 2.5. Unless the patient maybe has a prosthetic heart valve or other issues where they need to have them more anticoagulated. But generally that 2 to 3 range is where most physicians will keep their patients.
Well, and then along with the anticoagulants is also, you may see an NOAC, the newer oral anticoagulants. Okay. Those would be Xarelto, Pradaxa, and Eliquis. Yeah. Okay. So those are the NOACs. All right. And I'm telling you, Jay, lately, I don't know what it is, but I have had a lot of patients that are on Eliquis.
Yeah. Eliquis, and I'm seeing more Xarelto also. But
I'm seeing less Xarelto, and I'm not seeing much Pradaxa at all. I'm seeing a lot of Eliquis. Yes.
Yeah, me too. I'm seeing, and a lot of patients on Plavix.
Yes. Of course, now Plavix out there, audience, is our antiplatelet drug.
Right.
Okay.
Right.
And then there's another drug. I think such a cool name, Savasa. All right. It also, hey, let's go have a Savasa this evening or something. But
that sounds good.
That's a factor 10A inhibitor, and it's used for AFib, and that's not caused by a heart valve issue, as well as for DVT and PEs also. Yeah. Okay.
Yeah. Well, Xarelto and Pradaxa and Eliquis all have some factor 10A inhibition also.
Yes.
And also prothrombinase.
Yes. And the other one is Arixtra. Now that's going to be a sub-Q injection, and they're only going to be on that for an X amount of period of time. Whereas these other drugs, they may be on a little bit longer, Jay, because of the DVT or the PE.
Yeah. Yeah. It's been a while, but have you had a patient on Lovenox?
No, I haven't done a bridging in quite some time. I've had a couple of physicians, hey, do you need a bridge? I was like, no, let's don't.
Yeah.
I really don't want to go. Patients don't want to go through it, Jay.
No.
I mean, you're talking about shots in the stomach.
Exactly. So Lovenox is a low molecular weight heparin.
Right.
That was used back in the old days when we would take patients off of Coumadin to do oral surgery. And of course, in the hospital, we would have them on a heparin pump while they were in the hospital, turn off that heparin pump about 6 hours to 8 hours before the surgery, take them to surgery, and then put them back on that heparin pump within a few hours of surgery, and then eventually get their Coumadin levels back up. So this Lovenox, the low molecular weight heparin, came around, I guess about 20 years ago.
Yes.
And basically, it was used as a bridging medication. So instead of putting the patient in the hospital on heparin, the patients would give themselves injections of this low molecular weight heparin, and then stop the injections themselves, come into your office for an office procedure, and then start themselves back on the Lovenox until their Coumadin levels were back up to snuff. Now, how often do you take patients off of Coumadin for surgery?
I don't. I try my best not to. I've said this before on this show. I want to really get into my patient's history, and some things I like to look at their clinical signs. And I asked them to roll their sleeves up, Jay, if they've got long sleeves on. If they're bruised on both extremities, then I'm going to stop it, because they're going to bleed. They're going to bleed after I remove a tooth. Or I asked them, have you ever had a tooth removed? And they tell me yes. How long did you bleed? Oh, about a week. Well, guess what? I'm making a phone call.
Yeah.
All right.
And that was before they were on Coumadin.
That's right. So, I mean, it's just spending a little time diving in with their history right there, both their medical and surgical history as well. Yeah. And, but a lot of, I don't, Jay, because we've said it before, we can stop bleeding. However, there's times when we get burned. None of us are perfect at this.
No, I'd say once a year I get a call on a Saturday afternoon. You took out my tooth on Friday and it's still bleeding, and they're on Coumadin, so I've got to go in and pack the site and cauterize. But it's pretty uncommon. Most patients actually do really well. We just pack the site with oxidized cellulose, Surgicel, or gel foam, or a combination of the two, and pack it into the site, a couple sutures to hold the packing in place, and they really do pretty well. You can't just put a suture, because a suture is not going to hold the clot in place. The reason you use suture is to hold the packing in place, not to hold the clot in place. The clot's just going to dissolve right through the suture. And so that's another thing that comes up at some of lectures, is they have a patient, or some of the lectures I've given, someone will ask, is it enough just to put a suture in a patient that's on Coumadin? And the answer is no, you have to pack it. The suture is only to hold the packing in place.
Jay, if everybody's listening to us wants to make their life easier on anybody on an anticoagulant or antiplatelet, and you take a tooth out, I would pack the socket, I would stitch it, and you're going to have a good night.
Yeah.
All right.
That's for sure.
I mean, seriously, instead of like, well, you know what, let's just give you a damp gauze, maybe a damp gauze with some tea bags, bite down hard and all that. There's a good chance you may get a phone call. All right.
Yeah. And nobody wants phone calls.
No, I mean, we're all there for our patients, every one of us. Okay. But a little bit of defense right here can keep that from happening. Plus, you're going to get an anxious patient as well, and you're going to get an anxious family as well. Like, hey, my mother or father's still bleeding. What should we do now? Okay. Right. So spend a little extra more time and a few more supplies in your office, and I'm telling you, it will be a blessing for you.
Yeah.
Okay.
That's for sure.
But pack the socket really tight, stitch them, and just watch them a little bit, okay, before you discharge them.
Don't let them go until you know they've got good hemostasis. And as an aside, that hemostasis is really important for healing. Good healing begins with a good clot. And if we don't have good clot formation, the patients are going to have delayed healing. And we sometimes see this in patients who are on Coumadin, even though we've packed them. They just take longer for the sites to heal. So you want to keep that in the back of your mind.
Yeah, because I look, and not too long ago, Jay, I had a guy that I did that. And then his son called me. I just told everybody to pack it. I packed it. I stitched it really good. I let him sit there. I watched. He left my office CDI, clean, dry, and intact. All right. I get a phone call late that evening. All right. And his son says, "Hey, look, I think my dad might still be bleeding. What do I do? Hey, I'll meet you at the office. All right, come on. Are you sure?" I said, "Yes, that's what I'm here for." All right. He had some liver clots right there. He had a little slight ooze. I evacuated the clot, repacked it, and then told him what to look for. I went over. I said, "Look, here's what's going to happen. You're going to wake up in the morning. You might have a little crusty lip or something like that from bleeding. That's normal." And sure enough, but I got him off the Eliquis. I called his cardiologist, said, "Stop it." All right.
Yeah.
So, and he was on it for AFib as well too. We stopped the Eliquis for 3 days. Everything did fine. He A-okay. All right.
And the key
but that's a rare situation. Okay. But you got to know how to handle that complication.
Yeah.
All right.
So if a patient comes in with a liver clot, you want to remove that clot. You want to clean everything up. You want to get down to basics, see what's going on, see where the bleeding's coming from, and manage it. So as long as there's liver clot there, it's never going to stop bleeding. You gotta clean that out, debris, numb the patient up, clean out the site, see where the bleeding is coming from, pack it, suture it, and hopefully everyone can go on and enjoy the rest of their evening or weekend after that.
So, Jay, you said something about the Inr range. And so, most situations, everybody shoots for about a 2.5. Target range is 2 to 3. And, I had a guy a long time ago. I remember we did have some oozing afterwards. And I talked to the cardiologist. He tested his Inr for him. And he said, well, it's getting down to like a 1.5. He said, "I'm getting nervous." And I said, "Oh, I'm getting happy because we're getting back to normal. I can stop his oozing right there as well too." And so if you take out teeth, you're going to have a situation with an anticoagulant or an antiplatelet. All right.
Yeah.
It's going to happen. Nobody can ever say, "Oh, I went 30 years and never had a bleeding issue." Well, then you never took out,
many teeth.
Right. You didn't take out a tooth then. Okay. All right.
Now the other
let's
drugs,
be real here.
The other anticoagulants though will not affect PT and INR the way the Coumadin does,
right?
Because they work by different mechanisms, especially the newer ones is Xarelto, Eliquis, Pradaxa. They are by different mechanisms, and they basically will also indirectly inhibit platelet aggregation, but their mechanism is more through factor 10A. And so, which is part of the common pathway. So the the PT and INR are not going to be affected.
Well, and then when we get to the antiplatelets, talking about Plavix or Brilinta, Effient, excuse me, those are P2Y12 inhibitors, and the P2Y12 is a chemoreceptor for the adenosine phosphate.
Yeah, it's an ADP receptor that's right. It's important for activating platelets and eventually the fibrin cross-linking.
Right. So like you said, it's important in platelet aggregation. So now we've got an inhibitor, therefore the platelets can't clump. So therefore your blood just
keeps
thin.
going.
That's right.
And in fact, I've seen more severe bleeds in patients who are on Plavix than patients on Coumadin.
Jay, do you get an INR every time before you take out a tooth?
Nope, not anymore. I used to back in the old days, but that's when we were taking patients off of Coumadin for a while. So now the patient's been stable for a while, and the patients will know, what's your INR, how often do you get it checked? And most patients are pretty well educated. And if they've had no major changes in diet or they haven't been sick or anything that can throw off their INR, you can pretty much be assured that their INR is going to be in the normal range for them. And so there's no reason in my mind to go get to get an INR that day or the day before.
Well, you nailed it, Jay, because look, many places now have coagulation clinics. Okay. These patients go in on a routine basis. They get it checked. And if it's been normal for months, you know, like you said, they'll know it. Just like your diabetics are going to know their A1C level. Okay.
Right.
All right.
Exactly.
They're going to know that INR because it matters. All right. Because we don't want to get it above the 3.0 or 3.5 range. Okay. It's too thin now. All right. Or we don't want to get it below the 2.0 while on this medicine also. So
yeah, that's better for us, but not good for the patient.
Correct. They're going to know their INR levels. All right. And if they say, well, it's been a while since I got in, and then you could call the physician and say, hey, look, just want to consult with you on this. What do you want to get one?
Yeah. Yeah. I mean, like I said, especially
most patients are going to be current.
If the patient's recently been ill, or they've started a new medication, or they're on some fad diet, or something has changed that can affect their INR, they're going to be pretty stable, and you really don't need to test them right before surgery.
And you know, Jay, I know we got to wrap it up, but the other thing too, as far as an interaction, if these patients are on this, they've got to be careful in what they eat. If they eat a lot of rich vitamin K foods, okay, and I mean like broccoli, spinach, cabbage, which are all good for us, okay. All right. I mean, you can have some, but I mean, you can't consume large amounts of this because that could affect it also.
Right. So patients have to know. And the other, I mean, just like with grapefruit can affect metabolism of many drugs. So
absolutely.
What you think
that'll be a talk of its own when we do that one.
Yeah.
I can't wait for that.
Yeah. We'll have all the grapefruit growers chasing after us with their pitchforks.
All right. Well, look, man, that's a great show right there.
Yeah.
You know, talking about all of our colleagues out there, because everybody's going to face patients on some type of blood thinner. All right.
And
you can't have enough information about this stuff. That's my opinion.
And we did talk about with the sulfur drugs, but also there's the same interaction can occur with macrolides like erythromycin, azithromycin, and with erythromycin too.
That's right.
So we got to be careful when we prescribe and the quinolones like ciprofloxacin that we may give patients who are allergic to all other medications. We may want to use that might be our drug of choice. So if we have a patient who's on Coumadin and we're restricted to what medications we can give them, it's not a bad idea if you can to send a culture and sensitivity so you know what would be the most effective drug to put the patient on, especially if it's one that could interact with their warfarin.
Love it.
All right.
Okay.
Well, that wraps it up for today. Our next get-together is going to be on March 10th. I can't believe we're already going to be into March.
Hard to believe. You know, Jay, I got to put a shout out for PharmaDent, our 15 medication program for the entire dental office. It's available at www.smarttraining.com.
Sounds good. And we'll have more information about this at our next time on March 10th also.
Yes.
And we'll be here at 5 o'clock Pacific time and 8 o'clock on the East Coast. Until then, if you have any questions or comments, you can always post them on our YouTube channel, on our LinkedIn channel, on our Facebook channel. We check all those on a pretty regular basis, and we're happy to answer any questions that you might have or any suggestions you might have for topics.
We just thank you for watching the show and all that. I mean, we're about you. We're practicing dentists just like you are every day, and so we got to know this stuff, and we just thank you so very much. All right.
Thanks.
Good night, everybody.
All right. Take care.